assessment pattern from MNC has come, and that is going to be followed for your batch also. So you must have seen that assessment pattern as has been circulated in your WhatsApp group. So accordingly, you have to submit your assignments, and that will be going to stick in your logbook. So that will be looked in the final evaluation. So everyone, if you are being given any assignment or anything in seminar, project work, every record you have to maintain in your logbook. Now coming to the antidepressants and antimanic drugs. Now what depression is? This is a mood disorder. Now everybody has some mood fluctuations. Now based on whatever the reaction they give or the emotion state that went through because of something which happens in their life. Now when it persists for a longer time, this mood disorder, that this is something endogenous problem, then it becomes a disease, that is depression. Now what happens here? Patient feels sad all the time and loss of pleasure in all the activities, lethargic. There is also associated with certain symptoms like loss of sleep, loss of appetite, constipation, etc. So these are the various symptoms which happens in depression. Now what happens? What is the basic pathology behind it? There is decrease or depletion of monoaminergic. So there is a depletion of, whenever there is a depletion of monoaminergic activity at the synapse, close the door, or decrease in the transmission of the monoamines. Now this leads to depression. So the basic thing is, the basic pathophysiology behind is the depletion of the monoaminergic transmission. Now what happens in mania is just the opposite. Now there is usually in mania, as you see, it's usually seen in onset is before the age of 30. As you are seeing elevated mood, speech, weight loss, grandiosity, delusions and all that is there in the mania. The just opposite which happens in depression. And sometimes it occurs in cycle, that is known as bipolar mood disorder. So the objective for this is you should be able to classify the antidepressants, should be able to enumerate them, describe the mechanism of action, adverse effects and use, describe the advantages and disadvantages of SSRI. SSRI is the most important class as an antidepressant because this is the first line choice as an antidepressant. Explain what are SNRIs and atypical antidepressant and their important characteristics. Now there are various types of depression. Reactive depression. Reactive depression is reaction to what happens in your life, to the situations, to the various occurrence which happens, reaction to that. Now when it persists for more than 2 weeks, this kind of mood disorder, there is some endogenous problem which could have happened which has resulted in endogenous depression. So in reactive depression, you need counseling only. The patient needs counseling. For the endogenous depression or the bipolar mood disorder, the patient needs to be given antidepressants. But in bipolar mood disorder, there is also you need to give a mood stabilizer. That is lithium or sodium valproate. So this kind of drugs or antipsychotics, this kind of drugs are also need to be given with and without antidepressants as a mood stabilizer in case of bipolar mood disorder. Because which is more dangerous, mania or depression? Mania. So mania is more dangerous as compared to depression. Depression patients they usually isolate themselves, but mania they have a high tendency, they can harm anyone. So they are more dangerous as compared to depression. So So what happens in the limbic system? There is some neurotransmitter abnormality. If there is increasing dopaminergic activity, it may result in psychosis like schizophrenia. If there is depletion of this monoamines, norepinephrine, serotonin, it may lead to depression. And if there is increase in this norepinephrinic activity, this is resulting in mania. Now, what has been hypothesis which has been given in the depression? Now, there is depletion of this monoamines which result in reduced receptor sensitivity. Now, this reduced receptor sensitivity will reduce the signal transduction. Now, this reduced signal transduction reduces the C-force gene expression. Now, the C-force gene expression decreases the brain-derived neurotrophic factor. Now, this brain-derived neurotrophic factor, it is responsible for neuronal synaptic plasticity and neuronal growth. This brain-derived neurotrophic factor is important. So, basically, it leads to the depletion of this brain-derived neurotrophic factor. And this brain-derived neurotrophic factor is also being metabolized by GSK3 enzyme. Now, this GSK3 enzyme, now this is, on this there is an effect of lithium which we'll see later on. So that's why lithium is also having some antidepressant effect. Why it is having the antidepressant effect, we'll see when we'll deal with the antimanic drugs. So this is metabolized by GSK3, and because of the brain-derived neurotrophic factor depletion, it may result in depression. So how the typical antidepressant should work as per this hypothesis? By increasing the monoaminergic activity. How they can increase the monoaminergic activity? By inhibiting the reuptake. So norepinephrine transporter or serotonin transporter reuptake inhibitors can increase the monoamines. And another way is by inhibiting its metabolism. How these monoamines get metabolized? By monoamine oxidase enzyme. एसिटाइलकोलिनेस्टरेज कैसे किसको मेटाबोलाइज करती है? एसिटाइलकोलिन को. मोनोअमीन ऑक्सीडेज एंजाइम मेटाबोलाइजेस दिस मोनोअमीन्स. देयर आर अगेन टू टाइप्स, मोनोअमीन ए, मोनोअमीन बी. B metabolizes mainly dopamine. So that's why the drug which is acting on monoamine B, salicylamine, which is used in Parkinson's. So this is the mechanism which by typical antidepressants work. Any other mechanism other than that is atypical antidepressants. So there are two types of antidepressants, typical and atypical. Typical, which works by inhibiting this reuptake or inhibiting the metabolism and increasing the monoamines at the synapse and increase the synaptic transmission. Is it clear? Typical and atypical antidepressants, how they work? By inhibiting the reuptake, transporter, serotonin transporter, norepinephrine transporter. Either they work on both or they work on the individual transporter. They inhibit the serotonin or norepinephrine reuptake, or they work by inhibiting its metabolism. So they are of two types, reuptake inhibitors and monoamine oxidase inhibitor, or they could be tricyclic antidepressants. So this is how they have been classified. Reversible inhibitors of monoamine oxidase A. Monoamine oxidase A is the one enzyme which is metabolizing dopamine, norepinephrine, serotonin, all it. And where it is present, monoamine A, it is present in the peripheral nerve endings, it is present in the liver, in the intestine, where it gets metabolizes these monoamines. Now this inhibitor is moclobemide. Reversible inhibitor is only used now. Irreversible inhibitors like phenylazine and others, they have been banned. So they are no longer used. Then we have tricyclic antidepressants. Now these are again a second line antidepressant. In this we have norepinephrine and serotonin reuptake inhibitors, and predominantly norepinephrine reuptake inhibitors. You have all this with pramine or triptyline. They end with pramine or triptyline. So you have imipramine, amitriptyline, doxepine, clomipramine, and the spin is again there, but these are more important for you to remember. Then you have norepinephrine, predominantly norepinephrine reuptake inhibitor, diazepamine, nortriptyline. Selective serotonin reuptake inhibitors. Fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram and escitalopram. Okay, those which have been highlighted, they are also the drugs which are more commonly used among the antidepressants. So you have the selective serotonin reuptake inhibitors. Must remember these drugs: fluoxetine, fluvoxamine, paroxetine, sertraline, citalopram and escitalopram. Then you have the serotonin and norepinephrine reuptake inhibitors: venlafaxine, desvenlafaxine, duloxetine and milnacipran. Then atypical antidepressant: trazodone, niamcidine, mirtazapine, which is also known as noradrenergic specific serotonergic antidepressant. Bupropion, norepinephrine and dopamine reuptake inhibitor, tynaptine, anunaptine, vortioxetine and atorvastatin, which is norepinephrine reuptake inhibitor. So all these are reuptakes, so how they are different. So you must be having a question. They are all inhibiting the reuptake basically. Some with both, some with predominantly norepinephrine, or some with predominantly serotonin. So how they are different. So that we are going to study now, how they are different. So tricyclic antidepressants, though they work on both, so they must be similar to SNRIs, but they are not, because they also have an action on other receptors that they also have a direct effect on adrenergic, cholinergic and histaminergic receptors, and by blocking these receptors they also have the side effects of antihistaminic side effects or anticholinergic side effects or adrenergic blocking side effects. So they have a lot of side effects, and that's why they are the second line drug. Their effect comes in, whenever you start antidepressant, their effect comes in 2 to 12 weeks. They does not have an immediate effect. Now why this effect comes in 2 to 12 weeks is because जब मोनोअमीन यहाँ पे reuptake inhibition होगा, so this will increase over here. This will desensitize the autoreceptor like 5-HT1A or alpha-2 receptor. So this will be desensitized. Now because of the desensitization, there will be decreased release of norepinephrine and serotonin. Now after some time there will be adaptive changes which occurs at the pre and the postsynaptic receptors gradually in 2 to 12 weeks. So then there will no longer be decrease in the release of norepinephrine and serotonin, because अगर agonist continuously present होता है receptor पे, down regulation of the receptors occurs. So then their effect will be neutralized and there is increase in the transmission of the monoamines because of these adaptive changes. So that's why this is the theory behind that why their action is delayed. So this can be asked why their action, antidepressant action is delayed. Antidepressant action is delayed because presynaptic and the postsynaptic receptors, their adaptive changes, it takes 2 to 12 weeks to improve the monoaminergic transmission at the synapse. Is it clear? Mechanism is clear. क्या होता है mechanism? Receptors block हो रहे हैं यहाँ पे. पहले बताओ mechanism क्या है? All of you can answer. What is the mechanism? Reuptake inhibition. Reuptake inhibition by acting on which transporters? SERT, serotonin transporter, reuptake transporter, or norepinephrine reuptake transporter. They inhibit these transporters, they inhibit the reuptake. Now what happens after some time? Because of the autoreceptors, there is decrease in the release of norepinephrine or serotonin. But after some time, this desensitization of the receptors will occur, and there are adaptive changes which occurs later on, which at the presynaptic and the postsynaptic level, which causes increase in the monoaminergic transmission. Okay, so this is the answer why they have a delayed action. So whenever this question will be asked, will you able to answer this? Okay, sit down. Now these are the various side effects, anticholinergic side effects. Because of the M1 receptor antagonism, dry mouth, constipation, urinary retention, blurring of vision. These are the anticholinergic side effects. So this will be there. H1 receptor antagonism, there is sedation and weight gain. Adrenergic alpha blocking effect, postural hypotension, tachycardia. There is a direct membrane effect is there, reduced seizure threshold, and arrhythmias can also occur. Sexual distress again, and switch over, because if there is a bipolar disorder, you are giving antidepressants, switch over can occur, you have to be careful. Sweating, fine tremors, and because they are in the depression, there are chances that they consume more amount of the drug, and which may result in acute poisoning. So these are the various symptoms which can occur, which are the side effects which occurs. What are the main side effects? Antimuscarinic. Antimuscarinic side effects? Blurring of vision. Then you have antihistaminic, sedation and weight gain. Sedation and weight gain. Alpha blocking effect, postural hypotension and tachycardia. Postural hypotension and reflex tachycardia. Okay? Then direct membrane effect. Direct membrane effect, they also have a direct membrane effect that may cause arrhythmias or seizures, decreasing seizure threshold. Then sexual distress again, and switchover can occur in bipolar disorder, sweating and fine tremors, and acute poisoning. Okay, so these are all the side effects. So therefore it is used in resistant depression only. There is a variable effect, and because of all the side effects and because of the lag time, they are used as a second line drug and as in resistant depression only. So what are the major limitations? The second question which can be asked, what are the major limitations with tricyclic antidepressant? Okay, so all these are the major limitations with the tricyclic antidepressants. Frequent side effects, low safety margin, lag time, insignificant number of patients respond incompletely and some may not respond. So there is a variable responses. Then we have this monoamine oxidase inhibitor. We have discussed MAO and MAOB enzyme. But there is important side effect which can occur when you are giving the monoamine oxidase inhibitors, that is cheese reaction. The cheese and other substances like beer, they have tyramine. इसमें क्या होता है? Tyramine होता है. Tyramine, it indirectly releases the norepinephrine. Now this tyramine gets metabolized by the intestine and the liver monoamine oxidase enzyme. Now when you give the irreversible inhibitor, tyramine will not be able to metabolize. It will cause indirect release of the norepinephrine. Now because of the large amount of indirect release of the norepinephrine, what it can cause? Can cause hypertension. So this hypertensive crisis is what is cheese reaction. So therefore, the irreversible inhibitors are no longer used and reversible ones are used. Reversible monoamine oxidase A inhibitors have the advantages. They are short acting. They does not have the food and the drug interactions, which was there with the irreversible ones. They does not have these side effects which the tricyclic antidepressants were having. So they can be used in elderly patients who need a shorter acting drug or a mild to moderate depression or social phobia. So these were the side effects: nausea, dizziness, headache, insomnia, rarely excitement, and liver damage. So you have to do the monitoring. Liver parameters have to be monitored. Now another thing, when you're giving one antidepressant and you start the other antidepressant, large amount of serotonin may cause serotonin syndrome. So no two drugs should be combined which has an increase in the serotonin level effect is there. So what is serotonin syndrome? That can be our serotonin syndrome that includes muscle rigidity, fever, seizures, all this because of the increase in the serotonin level. So increase in the serotonin level, they have the serotonergic receptors, 5-HT receptors that may increase the anxiety, increase the seizure, decrease the seizure threshold. All these will happen when there is increase in the serotonin level. Some pain medication, SSRIs, tricyclic antidepressants, they all, when you are giving with these antidepressants, you have to be careful. They may cause serotonin syndrome. So what is the important drug interaction? What is the important food interaction? Cheese reaction with the food, drug interaction, serotonin syndrome. Remember the serotonin syndrome. Very important class is selective serotonin reuptake inhibitors. Why this is the important class? As the name suggests, it has a selective action on serotonin reuptake only. So you don't have the tricyclic antidepressant side effect, do not precipitate convulsions, do not cause cardiac arrhythmia, no effect on cognition or psychomotor function, and relatively safe and have a better effect, better tolerability. So this may be asked, why tricyclic antidepressants are not preferred, why SSRIs are considered as a first line drug. Very important question to be asked as an antidepressant. So you must be clear now why it is the preferable antidepressant, because of the selectivity of the action. Is it okay? Now among these SSRIs you have some specific properties which you should remember that can be asked in your MCQs. Escitalopram, that is the most specific SSRIs. Okay, why it is the most preferable? Because this is the most specific SSRI, escitalopram. Fluoxetine is the prototype drug, it is the longest acting. And fluvoxamine is the shortest acting. And paroxetine is the most teratogenic drug. And sertraline has the least effect on the platelets, and thereby they can be given with warfarin because it will not cause the bleeding. Because the drug interaction of this drug is, they can cause, if given with warfarin, because they have an antiplatelet effect, if given with warfarin, it may cause bleeding. They may increase the bleeding risk. That is least with sertraline. So this question is asked, the answer is sertraline. So these are the important MCQs which is asked in this. Side effects of SSRI: nausea, anxiety. Why this nausea? Nausea, vomiting, diarrhea will be there. Why there is nausea, vomiting, diarrhea? 5-HT3 stimulation at CTZ or at the intestine, 5-HT3 stimulation may result in nausea, vomiting, what can you give to avoid it? What can be given to avoid it? 5-HT3 antagonist, ondansetron, and specific to the intestine, aldosterone, which is also given in IRB. So in this inflammatory bowel disease, again this is given, but it is only effective in females, not in males. Okay, aldosterone. So there is this species difference in the action of a drug with aldosterone, which is effective in females but not in males. Then anxiety, तो अगर आप इसको दे रहे हैं, तो फर्स्ट लाइन, अगर आप किसी पेशेंट को डील कर रहे हैं, डिप्रेशन का पेशेंट है, आपने स्टार्ट करी SSRI, ठीक है ना, इफेक्ट कब तक आएगा? एटलीस्ट 4 वीक्स, 4 वीक्स के बाद आपको उसका इफेक्ट आएगा. उसके बीच में यू स्टार्ट विद बेंजोडाइजेपिन. व्हाई बेंजोडाइजेपिन हैज टू बी स्टार्टेड? Because anxiety will be there. Why anxiety is there? Because of stimulation of 5-HT2 receptor. Because of the 5-HT2 receptor stimulation, there would be anxiety, and then tolerance of this effect will come. But initial 4 weeks you have to give benzodiazepine when you are starting SSRIs. If there is no response to SSRI after 4 weeks, 4 to 12 weeks you have seen, but there is no response, then you start with SNRIs. Okay, then you start with SNRIs. Then there is insomnia, that is again because of anxiety. Sexual dysfunction is again a very important side effect with this drug, and the drug interaction, they are cytochrome 2b6 inhibitor. So if in cancer patient, if there is a breast cancer, tamoxifen is given. Tamoxifen get metabolized by cytochrome 2b6 into an active form. ठीक है? Cancer patients are more probable to go for depression. So if you are giving this therapy in a cancer patient who is again going for a depression also, you have to be careful with this drug, important drug interaction, the tamoxifen failure will occur. Okay, because it is inhibitor of cytochrome 2b6. So the drug interactions, again you have to be careful with SSRI, and again SSRI if you given with the pain medication or again other antidepressant, there is a tendency to cause serotonin syndrome, another important drug interaction. So these are the various side effects. Usually adaptation phase occurs within 4 weeks. Side effects are more manageable compared to the monoamine oxidase inhibitor and tricyclic antidepressant. Sexual side effects are common. Serotonin syndrome, you have to be careful, and discontinuation reaction in some patients, you have to be careful. कभी भी antidepressant आपको suddenly withdraw नहीं करनी है. That has to be withdrawn or tapered off. ठीक है? Suddenly you don't have to withdraw. Like beta blockers, you don't have to suddenly withdraw. Similarly, this antidepressant also will not have to be suddenly withdrawn. You have to taper it off. Otherwise, this discontinuation reaction may occur. So what are the various uses? They are also used in depression, but again there is a very good drug for other phobic disorders or obsessive compulsive disorders or eating disorders or premenstrual dysphoric disorders or other anxiety disorders or impulsive disorders like kleptomania and in chronic somatic illness. Adjustment disorders, so various kind of disorders they can be given with anxiety disorders and in depression. So they have a broad spectrum of action. Then we come to SNRIs. SNRIs, you have venlafaxine, duloxetine, milnacipran. In this venlafaxine, they are the fastest acting and they have the minimum drug interaction. This duloxetine is the longest acting in this. Similar side effects is in SSRIs. क्या side effect है SSRIs के? Drug interactions, sleep disorder, insomnia, sexual dysfunction, all these were the side effects. ठीक है? Similar side effects are there, but because of the norepinephrine, there is one more important side effect is they may also cause hypertension. Uses similar with duloxetine and milnacipran have an additional use in fibromyalgia, and duloxetine can also be given in diabetic neuropathy or stress urinary incontinence. These are the two other additional use in neuropathy, diabetic neuropathy, and also in stress urinary incontinence. Duloxetine can be given. Now coming to the atypical antidepressants. So how atypical they work is, like first is trazodone, another class is nefazodone. Now they also, though they block the 5-HT reuptake, but they are having a 5-HT antagonistic effect. They have 5-HT2 antagonistic effect. They block the alpha-1 receptors, but they have the least antihistaminergic side effect. So they have the 5-HT2 antagonist effect, so they does not cause much of anxiety. But they also have at least antihistaminergic side effect, but they block the alpha-1 effect, so they may cause hypotension, and they also inhibit the 5-HT reuptake. Niamcinine, it increases the norepinephrine release by blocking the presynaptic alpha-2 receptor. So autoreceptor को block करके it increases the norepinephrine release. This is the mechanism of niamcinine or mirtazapine. But why it is known as specific serotonergic activity? Because it has its action, it blocks the 5-HT2 and 5-HT3 receptor, and it has a specific action on 5-HT1 receptor. So that's why it is known as noradrenergic and specific serotonergic antidepressant. कैसे इनका variation है to the typical antidepressant, that is again just you have to write whenever the atypical antidepressants will ask and the specific use. So trazodone and nefazodone, they basically have the 5-HT2 antagonistic effect and the reuptake inhibition. Niamcinine and all, they act on the autoreceptors, niamcinine and mirtazapine, and they are having a specific serotonergic effect. They block the 5-HT2 and 5-HT3, and they have an effect on 5-HT1. They also block the histaminergic H1 receptor. Bupropion, it blocks both norepinephrine and dopamine reuptake, so it is used in smoking cessation. It is available as a sustained release tablet, bupropion, which is given for smoking cessation. So that is the typical use of the bupropion. Then tynaptin and omeprazole, they rather increase the 5-HT uptake. And amoxapine, norepinephrine reuptake inhibitor, it blocks the dopamine receptor, and it is used in attention deficit hyperactivity disorder. Again, they have rotazetine, which is a 5-HT1A agonist, and velazodone, which is again a 5-HT1A agonist with serotonin reuptake inhibitor. So just you have to know their mechanism, how they are different. They are used in certain resistant type of depression where these typical antidepressants, they fail. So a 34-year-old male patient who was prescribed citalopram for depression has decided he wants to stop taking the drug. When questioned, he said that it was affecting his sexual performance. You are certain that he is also trying to overcome his dependency on tobacco products. If you decide to reinstitute the drug therapy in this patient, the best choice would be bupropion. So the best choice over here is bupropion. It does not have a serotonergic effect which is affecting which is causing the sexual dysfunction. And again, the patient is on the tobacco, so it will also help in smoking cessation. So these are the various uses of antidepressants. You use in endogenous depression, juvenile depression, elderly or heart patients, you can use moclobemide. After treating the depression, you have to continue it for 6 to 12 months as a maintenance therapy. Okay, SSRI is the first line. You can continue it for 1 year at least. This is also given as a prophylaxis for recurrent depression, SSRIs. In bipolar disorder, you also give a mood stabilizing drug. Electroconvulsive therapy is given in severe cases. This is used as a maintenance treatment, antidepressant. Acute episode treat kar nahi sakti antidepressant. So what you should give is electroconvulsive therapy. Now if there is an acute severe depression, immediate effect agar aapko chahiye, so then you have to go for electroconvulsive therapy. Okay, acute treatment, electroconvulsive therapy. Phobic state, anxiety disorders, pruritus, you have doxepin. Attention deficit hyperactivity disorders, you have more which is increasing the norepinephrine, predominant norepinephrine. Premature ejaculation, yes, quiet everyone. Depoxetine, which is a congener of paroxetine, because they delayed the ejaculation, so that is why they can be given in premature ejaculation. That is a side effect which can be used therapeutically. So depoxetine has a rapid effect, clomipirine has a slow effect. Enuresis, imipramine. Neuropathic pain, you have amitriptyline, duloxetine. Migraine, again amitriptyline as a prophylaxis, you give in severe migraine. Smoking cessation, bupropion. So what is the mechanism of antidepressant action? Yes. So use of antidepressant can remember as depression. D for endogenous depression, E for enuresis. You have P for phobia, R for recurrent panic attacks, E for eating disorders or bulimia, S for stress disorders, S for smoking cessation, I for impulsive disorders, O for obsessive compulsive disorders, N for neuropathic pain. So you can remember these uses with this mnemonic, this is depression. So these are the various uses, typical side effects of the antidepressants. Just some of the questions. Reversible and selective MAO inhibitor. Reversible and selective MAO inhibitor. Moclobemide. Chief reaction in MAO inhibited patient manifest as, कैसे manifest करता है? Hypertensive crisis. And its drug of choice? Phentolamine. क्या देंगे? Alpha blocker, phentolamine. Antidepressant having both high sedative and high anticholinergic activity. Highly sedative and high anticholinergic activity, amitriptyline. ठीक है? Which is having high sedative and high anticholinergic activity. Antidepressant which selectively block 5-hydroxytryptamine uptake. Most specific is SSRIs is selectively inhibited, and among that the most specific is escitalopram. A 65-year-old man was brought to the hospital with complaints of pain in the lower abdomen and not having passed urine for 16 hours. The bladder was found to be full. His son informed that he was depressed for the last 2 years, and only the day before a doctor had given him some medicine. Which of the following drug is the most likely to have been received? कौन सी हो सकती है? Which is causing anticholinergic side effect? SNRI does not cause anticholinergic side effect. SNRI is the fastest action among all, and it is the drug of choice when the SSRI does not work. Tricyclic antidepressant, that must be on the tricyclic antidepressant, and the most would be amitriptyline. Safest SSRI to be used with warfarin, sertraline. Longest and shortest acting SSRI, longest is fluoxetine and shortest is fluvoxamine. Most specific SSRI, escitalopram. Most teratogenic, paroxetine. Faster acting antidepressant, SNRI, venlafaxine. Therapeutic window. What is therapeutic window phenomena? At a specific range, their action is seen. So these antidepressants, they also have work by, again, अगर आपसे therapeutic window phenomenon कुछ drugs पूछी जाएंगी तो antidepressant again work on a therapeutic window phenomenon. अगर आप उससे ज़्यादा increase कर देंगे, then also their effect will not come, and if there is decrease in that, then also their effect will not come. So they also follow the therapeutic window phenomena. Then in the next class we'll be doing the antimanic drugs and the mood stabilizer. Thank you.